Hi, I'm Cassandra Calabrese. I wanted to briefly review how we approach outpatient management and prevention of COVID-19 in patients with immune-mediated inflammatory diseases. What is the future of the pandemic? It's unlikely to fade away and most likely will be with us in some form for a long time and really will morph into two epidemics, one of vaccinated healthy persons and one of immunocompromised persons who are vaccinated but unlikely to have responded fully to their vaccines. And this is this high-risk group we're going to focus on. We envision optimal outpatient management of patients with immune-mediated inflammatory diseases looking something like this. Involves an educated patient who has access to home testing and knows when to test, knows who to call about their COVID concerns, and then that practitioner that they call needs to know how to link the patient with the right care path. What tools do we have in our toolbox for prevention of COVID-19? We have vaccines. COVID vaccines still hold up very well against severe disease and death from COVID-19 in most patients, and being fully vaccinated, including appropriate boosters, holds up quite well, although this is not the case for many of our immunocompromised patients. Perhaps the most exciting tool in our toolbox for prevention is Evusheld, or tixagevimab, a subcutaneous anti-spike protein monoclonal antibody that received emergency use authorization in December 2021 for pre-exposure prophylaxis against COVID in adults and children who are immunocompromised and might not have adequately responded to COVID vaccines, or who have severe contraindications to receiving a COVID vaccine. This product has been shown to significantly reduce risk of COVID and severe COVID in patients who don't respond to their vaccines. We're very excited about getting Evusheld to patients who need it. We don't have enough doses for everyone, so this is how we approach our allocation and triage, really focusing on rheumatic disease drugs that we know decrease COVID vaccine responses and are associated with severe COVID-19 outcomes. First and foremost are rituximab-treated patients. Cyclophosphamide, mycophenolate mofetil, patients on a variety of combination immunosuppression, including high-dose steroids, patient with concomitant humoral immune deficits like common variable immunodeficiency, or patients with combinations of drugs and other significant comorbidities associated with poor outcomes like older age, interstitial lung disease. We think it's unlikely that patients on methotrexate, TNF inhibitors, IL-17 inhibitors, and some of the other drugs we use are unlikely to need Evusheld. What about treatment? There are fortunately several options for effective treatment of COVID-19 once infected, and these are indicated for patients with risk for progression to severe COVID-19, including older age, a variety of comorbidities, and being immunocompromised. There are two oral antivirals, both indicated to be given within 5 days of symptom onset. Nirmatrelvir or ritonavir or Paxlovid is a 5-day course that has unfortunately multiple drug interactions and also a risk of rebound viremia and symptoms, but not a reason to not give it to your patients who are indicated because it does reduce progression to severe disease and death. Molnupiravir is another oral antiviral option that is less effective at preventing progression, but a good option if patient can't take Paxlovid. And finally, anti-spike monoclonal antibodies. What we are currently using on this calendar date is bebtelovimab, which is to be given within 7 days of symptom onset to outpatients with COVID with risk factors for progression. So in summary, optimal management starts with an educated patient, a patient who can recognize signs and symptoms of COVID or have an awareness that they were exposed, know when they should seek treatment and who to call, and that there's an urgency to these treatments. Monoclonal antibodies, the current one we're using, actually needs to be given within 7 days, and antivirals within 5 days. That they know how to test at home, know when they need a higher level of care, like to go to the emergency room, and then know who to call. And this can also be confusing because our patients often see many different specialists, and knowing who to call is important. So this is something we discuss with our patients at each visit, especially high-risk patients. Lastly, what do we tell our patients now? Patients who are B-cell depleted and other heavily immunosuppressed patients are unlikely to have responded to COVID vaccines and should be counseled appropriately and linked to appropriate treatment and prevention modalities. These patients need to be aware of their risks and that breakthrough infection can be subtle, and have an awareness of when they should test and who to call when they test. We think this is all very important and take just a few moments of our visit with our patients to counsel them about these important prevention and treatment modalities and what they should do if they have concerns.